So what led you to become a psychiatrist and not a pediatrician or a dermatologist or whatever?
Well, I actually started out as a surgeon, a urologist. And when I came to the United States, I was doing a surgery residency in New York. So it was routine general surgery and OBGYN. Um, and then I like to say that I got married and came to my senses and realized that I wasn't going to have the life that I wanted, a family life, if I was a surgeon. And so I decided to switch to psychiatry, which was really the thing that interested me the most after surgery. So,
Hmm. And what particular strain of thought most influenced you? Adler, Jung, Rogers, Freud. Who really shaped your approach?
so I'm not a psychotherapist. That's not really my call to fame. I think I went to training in a very biologically oriented program. And that's really what I'm pretty good at, is the biological approach to medicine, rather than the theories of therapy.
But it's disturbing to me that psychiatry has moved away from talk therapy. I think in Jungian and Freudian traditions, people would talk to their therapist 2 or 3 times a week for years, and that's excessive. But now it seems like insurance companies have said, we want you to get that patient in and out, give them pharmaceuticals so they can cope, we'll deal with their symptoms. Do you think that's a valid criticism or not?
I don't think it is. There's multifacets to it. For therapy to be effective, you need to see a therapist 2 or 3 times a week. That's how it was structured and how it was designed. If you see your therapist once a week, that's also within the reason. I think you need to look at the patients that those therapists treated. They treated the upper echelons of society, those that could afford them. So by saying that, you're effectively, or people are effectively denying the middle class and the lower class a form of treatment because they can't afford it. And so the criticism is really invalid because it is an expensive therapy. It's an expensive treatment. And so who can afford it?
Hmm. Well, if I come to you and I'm severely depressed because I have a oppressive husband and I take pharmaceuticals that mask my depression, that doesn't really solve my problem, which is I
No,
should do something about the husband.
it doesn't. And I think that's where there is a happy medium between using the tools that are available to us currently, whether they're super effective or not, to treat the depression. So, what we advocate is really medication therapy as well as talk therapy at the same time. And that in itself has shown to be superior to any one over the other.
Hmm.
Um, so there's different types of therapy. There's individual therapy, there's group therapy, there's different schools of therapy, or cognitive behavioral therapy, dialectical behavioral therapy, whatever it is. But it is a combination of both. So you're absolutely right. The circumstances need to be resolved, and the symptoms, the current symptoms that impair one, need to be resolved as well.
So, how much time do you average with a typical patient? Um, Typically, it's 15 minutes for regular, like family doctors. What about for you?
We're about 15 to 20 minutes for a medication appointment.
Even
Uh,
an initial
no, an
appointment?
initial is longer. It's about an hour and a half.
Mm-hmm.
Um, Again, the choice is, do I treat 40 patients a week, or do I treat 120 patients a week? Knowing that an hour is an hour, so the reimbursement for an hour is really the same. Whether I see 3 patients or I see 1 patient, it's the same. So it's not about creating volume and creating money because I'm seeing more patients. I'm not charging them the same. It's an hour, it's divided into 3, and or 1.
Got
So
it.
it's not about that. I think my approach to psychiatry has been influenced to a certain extent by my initial training as a surgeon. Um, and that's why biological therapy kind of suits me personally. Is it's decisive. There is an intervention, and there is an outcome rather rapidly, um, rather than a slow cooker approach. You know, therapy takes time, repeated sessions. You don't go for a month of therapy; you go for years.
Mm-hmm.
So that has suited me more. But we tend to see the sicker patients that need more intensive care rather than the less sicker.
Mm-hmm. Have you heard of the energy psychologies where they tap on acupressure points on the meridians and they feel like they can move through stuck traumas pretty rapidly?
Okay. I'm
Uh,
not sure what the question is. I'm sorry.
but the question is, have you heard of them and like emotional freedom technique, tapas acupressure technique, thought field therapy? There's these whole algorithms of people who work with, including mental illness, with tapping on meridians and talking.
Yeah, I've heard of it.
Mm-hmm. Okay, we'll leave it there. I want to go back to your origins. What was there about your family of origin, your childhood, that led you to decide I want to be a doctor and I can do that?
Well, I wanted to be a doctor because I couldn't be an architect. Uh, my parents were both architects, and my father was a particularly talented architect. And so, to me, growing up and seeing him design all these buildings, and to me, it was all either architecture or nothing. And unfortunately, I don't have an artistic quality. And so my father would tell me, you would not make a good architect. You would not make a good architect.
Oh.
So I eliminated that field, and to me, became medicine. So
And what was it? Did you grow up in Egypt?
no, I actually grew up in West Africa, Nigeria,
Wow.
and till I was about 16. And then went to medical school in Cairo and lived there for about 10 years, and came here when I was 26.
Hmm. Cairo's an intense city. It's amazing to me that there's 4 lanes, but people think that it's 6 lanes. You know, cars are right next to each other. Just driving is an experience in Cairo.
Yes, yes. We had a friend go to Cairo with us, and he couldn't drive there, but he wanted to because it was like a video game, you know? Uh,
Oh my goodness. Um, do you, what was your culture shock when you first came to the U.S. at 23? What struck you as, oh, that's really a different approach to life?
Nothing really stood out. I think the methodical approach to dealing with things is really what fascinated me. There's a paradigm for everything. This is the way it should be done, and I think that allows people to do things even if they don't have the talent for it, and there's a system for it.
Hmm, interesting.
Yeah.
What are you finding in terms of the recent pandemic. People are afraid there'll be an epidemic of depression because people are isolated and anxious and afraid. What do you see in terms of your patients and people you know that being in isolation? How has that influenced their mental health?
Well, we're yet to see the effects, but what has been fascinating, we have been open for our patients to come in, and strongly believe in staying open for that purpose. So we've offered patients the opportunity to Skype or do their visits remotely. And the fascinating thing is most patients are choosing to come in personally rather than do it remotely. So that has been a very interesting finding. And I think it's really, there's a lot of anxiety about running out of medication, about things kind of unraveling and not being able to access services. That's been a major stressor. Our group therapy programs have been done remotely the past week, and that has been a fascinating experience. So we're yet to see, but I think what is clear is because of the restrictions on social contact beyond the home, people need to kind of take care of themselves, stay within a routine schedule, sleep well, make sure you're sleeping well, staying hydrated, exercising, and having a frequent contact with family members, with friends, even if it's remotely. Sticking to that schedule and normalcy allows one to stay within the compounds of, a normal life. Avoiding alcohol is probably a good idea. But also compliance with medication more than if you're taking any medication, and avoiding getting sick really is key.
I'm hearing lots of people say they're having trouble sleeping. What do you suggest for them besides taking sleep medication?
No, I wouldn't think of sleep medication as the first option, but establishing a normal life cycle if they're at home. If we're not going to go to work tomorrow, that means we can stay up later watching television. And that's absolutely the wrong thing. It's sticking to your normal routine. Exercising is very helpful for sleep. Unwinding. The big thing about that provokes anxiety is a lot of information and bombardment from the media of information that we're unable to process. What does it mean? What does it mean that the rate of mortality from the virus has doubled? What does that mean? And I think we focus on the tragedy and we focus on the sensationalism and we forget what the statistics mean. It is a pandemic. It is a deadly pandemic, not like the plague. It's a flu. Or a type of flu, different. We're not used to it. We've been through flu pandemics before, and this might be worse, but we survived. I mean, the number of people that die from the swine flu, from the bird flu, they're pretty high. This might be higher, but putting that in perspective, I think, is important.
In our Butte County, I think there's 11 cases and no deaths, so that isn't a huge amount, and it's not like tripling, doubling.
No, I think it's probably underreported for the fact that we're not testing enough people.
Right.
But what I was reading yesterday is really California and Washington, the curve in those two states is totally different than the rest of the country. And so I think the administration acted quickly in these two states. Social distancing is helpful and working, and has an impact.
In general, how do you take care of your own emotional health if you're seeing sad, depressed, anxious, troubled people every day, week after week? I mean, that can be very draining and burdensome.
Yes, I think part of our training is to isolate, not isolate, but contain the symptoms and the stories that we're hearing within a framework, and leaving that framework at work and not taking it home with us. I think it's part of our training. People might call it a reduction in empathy for people that are observing us while we're hearing these stories. It certainly seems like we're emotionless. I mean, our faces don't react as much as normal people would. But that's really to be able to wade through these traumas and difficult symptoms and be able to break it down and be able to help the patient if we're able to understand it. Not as a patient, but as a treater from outside.
Right.
So it's a boundary issue that's kind of ingrained into us over time.
Did you go through analysis yourself as part of the training?
No, I didn't. It wasn't available for us. I did try to do a psychoanalysis fellowship while I was in training, but that was for a short period of time.
To switch gears a little bit, I've been working on books about youth, global youth, and one of the striking things that's true in the U.S. and I think in other Western countries is the big increase in anxiety and depression among teens, especially among girls. So I wonder if you've seen that in your own practice, and if you have an explanation for why so many more depressed, anxious teens.
I think it's really down to the societal structure in Western society, a more isolationist family unit, a higher rate of divorce, a higher rate of infidelity. That contributes to the breakdown of the family unit, the way we always think about it. Father and mother and children, and then their grandparents and their grandkids and their uncles and aunts and their cousins on either side. So it's an extended family unit that is integrated and cohesive and strung together. With that breakdown, I think what stands out is the breakdown of the father-mother relationship. With the divorce rates skyrocketing, that has broken down that image of an intact family unit in the eyes of children. Because that's their source of comfort and security comes from that. And so when that is not there, there is an increased rate of anxiety, feelings of being anxious because I don't feel safe. And if you don't feel safe, you're going to be anxious, right? You're going to adapt to the new situation. You're going to get depressed because it's overwhelming. And you're going to get anxious because you don't know how to deal with it.
But
and then, go ahead.
That change in the family structure has been going on since the 60s, but in the last decade or so, there's been an increase in the rates of anxiety and depression, and already the family structure had changed. So I'm wondering if there's something else that you're seeing in addition to the lack of a cohesive mom-dad support system.
I think drugs and alcohol availability, marijuana is a big issue. These are things that are actually making things worse, mood-wise and anxiety-wise. Um, Society, it's a different society.
But what's interesting is Gen Y and Z are less likely to drink alcohol, have sex, get into trouble. So they're more conformist. I wonder if you feel there's an impact from social media, the phone in the hand all the time, if that has any effect.
I think in general, the age of the internet has brought on a higher rate of acquisition of information. We get much more information very, very quickly. And again, processing this is very difficult because you have to wade through it and find out what's real and what's not, because anyone can put up anything. And there's a constant bombardment with information.
Mm-hmm.
It's stimulating.
Mm-hmm.
So you're right. I think the social media aspect is an aspect of it. You're getting a lot more interactions, and they're not face to face. So more is being said that one might be tactful in saying face to face. But I think it's the constant stream of information that's too much.
Do you limit your own children's access to the internet, their phone?
I don't actually.
And they're doing okay.
They get anxious every once in a while. They deal with different situations, and I have to really walk them through. But it's a reality that one cannot deny or take away. So better be equipped to deal with it rather than not equipped.
Mm-hmm. Other people have faulted the rise of helicopter parents who overprotect, swoop in at any little problem, call their kids professors when they go to college. Why did my kid get a C on this test? So I wonder if you've seen any changes in parenting practices and being overprotective that turns kids into fragile teapots.
I don't see a lot of adolescents, so it's not really my specialty or forte. But I don't think that's abnormal. There is variability in parenting based on experience and based on goals. So we neither leave our kids to go through their difficult phases by themselves. They need guidance. Some people are overtly guideful and some are not. These are variances. I don't think we can classify people as this is a bad thing, don't do it. We are the sum of our experiences, and that's what makes each parent or each person unique and different from the other person. So how do we classify people as don't do this and don't do that?
What about the rise of autism? Do you think the increase is due to we just know more about it and it's being diagnosed, or do you think there's other environmental factors that are leading to more kids and young adults being diagnosed as autistic on the spectrum?
I think as technology has advanced, we're exposed to more during pregnancies, whether it be medications, whether it be environmental stressors, if you will, whether ingested or exposed to. Plus, we are diagnosing more and more, even on the lighter end of the spectrum. So there's more awareness, I think, from the public and mental health professionals about the importance of diagnosis of autism. So.
And are you seeing autistic patients?
No. I prefer that they go to a specialized government-sponsored entity like Far Northern Regional Center because of the integrated services that are available for them. I'm only able to provide one facet of the care that they need, because they need a lot of other services other than just medication.
Mm-hmm. And is there a medication for that kind of suits the symptoms of a person on the spectrum, or is it that there has to be environmental changes to accommodate their needs in school or whatever?
It's a multifactorial team approach, social, biological. There's everything, and that's why entities like Far Northern Regional Center are really best equipped to treat autistic kids and kids with Asperger's because of those reasons. They provide a vast array of services that are free for the most part, that no private entity can provide.
It's interesting to me because Greta Thunberg and some of the other climate activists, young people in Sweden, say that their autism presents them with a different way of looking at the world, which can be useful and insightful. So that was interesting to me to look at autism as something that could provide new insights.
I don't think it's the autism that provides the insight, but a lot of people with autism are actually very intelligent. And it's not mental retardation. It is a syndrome of social impairment, to a very large extent. But they're able to, they're very bright. A lot of them are. And so I don't think it's the autism that provides them this perspective, but it's the symptoms of it, the isolationist, the hyper focus on one thing or the other that allows them to see things in a different way because they're focused on it. And I think that's one of the, with every disaster, every issue, illness, there is always a bright side to things. It's just the way we look at things.
Mm-hmm. And you know what I think that's interesting about mental illness is that in a way we all have degrees of it. Like we all have dissociative identity disorder and multiple personalities and anxiety and depression, and we disassociate. So it's almost a matter of degree.
No, we don't. I disagree with you. It's important to distinguish symptoms, which are symptoms by themselves, could be called phenomenon, from an illness. An illness is an aggregation of symptoms that happens together at the same time and happens in a frequency and a pattern that is distinct to this illness. We don't have multiple personality disorders. Normal people don't. We act differently, but it's not multiple personality disorder. We might feel down and sad for a day, but it's not depression. So I think the distinction between symptoms that might occur in an infrequent, with lack of frequency and with a lack of a pattern is different from an illness which has a predictable pattern and grouping of symptoms that occurs at a particular frequency and for a particular period of time. That is an illness. So you could feel sad, cry all day, and not sleep at night, and the next day you're like, I need to snap out of this, and you do, and you're fine. That's not depression. Might go on for a day or two. That's not depression. That's a normal response.
Right. Your grandparent dies, you're sad,
Exactly.
You're depressed. It's situational.
Whatever. You're not sad and depressed. You're sad, you're grieving.
Okay.
I just want to, because I think what is very important to identify is people come to me and say, well, I'm depressed because it's normal life. No, you're not. That's not depression. Depression, where you're impaired functionally, socially, professionally, and have a group of symptoms that persist for a period of time and in a particular pattern, is depression, regardless of why it happened.
Mm.
The reason doesn't mean that you don't need treatment.
Got it.
And so that's an important thing. People come to me and say, well, I've been depressed all my life. And why haven't you done anything? Well, I thought it was normal. I thought everyone felt that way.
Mm.
So I think it's imperative that we educate people on what is treatable and why it should be treated, simply because it can get worse, and address those symptoms immediately.
I was really struck. The World Health Organization said that within 20 years, more than depression will be the most common health problem in the world, so that they predict an increase in the number of people who are depressed. Do you have any thoughts about why? I mean, that's a huge statement.
I think it's a very true statement, but I think there's probably multiple reasons. Rural societies that existed 100 years, 150 years ago in the US and still exist in some areas of the world right now, with modernization, life is changing and style of living is changing, the pace of life is changing, the pace of information is changing. We're exposed to a lot of stressors in life that mean, for the initial period of time, is we're not all going to be coping with that change well. And if we're unable to cope, what are we going to do? We're going to get depressed and anxious.
Mm.
So I think it's the pace of life that's picking up. Some areas in the world are catching up to modernization, and modernization is moving forward with more.
There was a book that criticized the kind of globalization of American views of mental health and imposed it on other cultures in a way that wasn't really suitable, so that more people start thinking, oh, I'm neurotic, I'm depressed, I'm anxious. I don't remember the name of that book, but I'm wondering if there's kind of a colonial aspect to projecting our view of what life is like.
Well, I think life to each group of people is different. The values of life are different. What we project as goals in our lives are different. Different cultures have different values. And trying to impose one particular view on a different culture isn't going to happen. It's not. But what other cultures see is the sensationalism of Hollywood, and without really understanding. And we don't see the rest of the world. So there's a disconnect, you're absolutely right, but nothing fits everyone. And
Right.
I think that is even in medicine, we're talking about personalized medicine. What does that mean? That means that every person is treated separately in a very, personalized approach.
I'm thinking of I read a quote from a girl who was an orphan, maybe from Uganda, who was adopted in the U.S., came from a poor background, and she said, where I came from, people were happy. If there was a simple little stone, you could make it into a toy or something, and she was so surprised to come to this wealthy country, and people are stressed and worried and anxious and fearful, and not appreciating the simple pleasures of life.
Well, it's very simple. If you live in a farm or live in West Africa on a farm in poverty, you're planting your food, you're getting your drink from the well, and you're doing agricultural work, right? It has a pattern, has a seasonality to it. there's a predictability to it. If you are richer, you're still doing the same thing, but on a bigger scale. But there's predictability. In the US, it's totally different. You have to go to the store to get your food, right? And you have to go to work to earn a living, to spend on rent, car, and food. Well, if you don't have a living, what are you going to do? And that's stressful because people live paycheck to paycheck. So they're constantly anxious. What am I going to have tomorrow? Well, in the backward societies or the undeveloped societies, it's very simple. You go out, you get something from the land, and that's it. So you're not anxious.
And you have social support. You have your tribal rituals and age groups and grandparents. So there's not the isolation of the nuclear family that moves all over the U.S. and doesn't have those traditions and structures. I'm interested, of course, in treatment, and some studies say that according to, for example, a review of more than 700 patients, antidepressant medication didn't really help. It did help people who had the most severe depression when compared with placebo. So I've read lots of reports that medication for depression and anxiety is very iffy.
Very iffy is...
in terms of helping people alleviate their depression or anxiety.
So let me clarify things a little bit. Medication's efficacy in resolving symptoms is about 35%, a generous 35%.
Wow.
So that means in 35% of patients that present, their symptoms would be resolved with an antidepressant. That leaves 65% with a variable between significant reduction of symptoms to no reduction of symptoms. There is a landmark study that showed that after treatment with up to 3 or 4 antidepressant medications, not necessarily at the same time, there is a significant improvement in symptoms in 67% of patients. Meaning that after a year or two of treatment, using up to 4 medications in an attempt to resolve those symptoms, 67% of those patients will have significant reduction of symptoms. That leaves a good 33% with what we call treatment-resistant depression. So it is a far cry from taking an aspirin for a headache or taking your antihypertensive medication. Knowing that antihypertensives control the symptoms but do not treat the cause. And we have to think about that concept. Because if you stop taking your blood pressure medication, your blood pressure is going to go up, right? Mm-hmm. So what is treatment then? We're just maintaining symptoms and controlling symptoms. We're not treating. Treatment in cancer means resolution of symptoms. How good is that? It's not that good. The rates, the ratios. Chemotherapeutics are the worst medication with side effects. Yeah. And what is the rate of remission of cancer? So let's put things in perspective. Mental health, like any of the other illnesses, is a chronic, recurrent illness that, for the most part, most likely afflicts people for a lifetime. For the most part. That means you're going to struggle with treatment for the rest of your life. So, What are we then looking for as far as treatment? Remember, we're not treating the histrionics that Freud is treating. We're treating another subset of illnesses other than what Freud was treating. So it really upsets me when people focus on therapy and say, well, psychiatry isn't doing therapy. Well, yeah, we're not treating the rich that Freud was treating. We're treating the masses, the big numbers that need to be treated. And how do we treat them if we don't have enough people? So those big numbers have to find a way over a span of lifetime of periods of time where their improvement is extended, the times where they're doing well are longer, and the times where they're doing bad or ill are shorter and less frequent. So we take chronic depression, for example. If I can't get better with therapy and with medication, why don't I do electroconvulsive therapy? Because it is the highest rate of improvement.
What side effects? I don't remember. What are the other side effects?
So, like the cognitive impairment, for example, that's the most pronounced. Let's compare to a patient with cancer. They're going to go on chemotherapeutics. Your hair is going to fall down. You're going to lose weight. You're going to be throwing up every day. Let's put things in perspective.
Yeah.
Let's be honest with each other.
Yeah.
And do people do it or not? I think what society has done is stigmatized mental illness, stigmatized the treatments that are effective, and denied people, because of that stigma, a better life. And that is sad, because it is our doing.
So are you saying with electroshock therapy that people get over their depression, so it's worth the cognitive impairment, loss of memory, and that kind of thing?
What I'm saying is that what it does work, it works really, really, really well. To the point that these patients, when they do have memory impairment, to them it is worth it. And that's feedback from patients. I haven't had depression, I haven't had electroconvulsive therapy to be able to sit in their shoes and say this. And I'm not saying it out of self-promotion or arrogance. I'm saying it based on what I've seen as a physician. You look at the other side of it, when it doesn't work and patients are burdened by the side effects, it seems like it is worse. Absolutely. You know, there's 1 in 4 chance that one will not have a response. There's 3 out of 4 chance that you will have significant improvement. So when it comes to it, who am I to tell a patient that is severely depressed for years, you don't deserve this, you shouldn't do this? Who am I? I don't have the right. And I don't have the right to tell patients this is what you should do as well. When it comes to electroconvulsive therapy, because of the side effects, and because I have not experienced those side effects, I do not feel that I'm qualified to tell patients this is the only thing you should do. My job and my duty is to tell them what their options are, to educate people as to what your options are, what the outcomes are, what are the chances of getting better, what are the side effects, and empower the patient to make an educated choice rather than a choice based on fear.
Got it. In terms of the brain chemistry, neurotransmitters, is there a difference between anxiety and depression? Are they a different chemical reaction?
Yes. it's a very intricate system, and I don't think we fully understand the intricacies of the neurotransmitter pathways in the brain. But in general terms, serotonin seems to be a dominant factor in the neurotransmitter systems in the brain. Those are modulated with others. There is a close interaction with other neurotransmitters. Dopamine has a big role in some areas of the brain. Norepinephrine has a role. Some of the inhibitory neurotransmitters like GABA have a significant role played in anxiety, for example, not so much in depression. So it is a very intricate web of neurotransmitters, and different medications have different purposes and different roles to play.
So the medications change the chemistry of GABA or dopamine or whatever it is. Is that how they work?
So any message that goes in the brain is a function of a chemical transmission and a electrical transmission. The nerve bodies are electrical, and the nerve endings are chemical. So to bring about a change, anything, if we're talking right now, there are messages running through our brains, stimulating certain areas, releasing neurotransmitters. So with medications, they're bringing about a change in the rate and expression of certain neurotransmitters, either by making them more available or less available in certain areas in the brain.
So they inhibit or expand the production of...
Stimulate, yes.
Yeah, stimulate. I'm hearing that there's a lot of neurotransmitters in the gut, and they have a lot of influence on our emotional state. So do the medications work on the neurotransmitters throughout the whole body?
They affect neurotransmitters in the different body. Remember, I mean, the concentration of different neurotransmitters are in the brain and the nerve system that goes throughout the body. So it affects both.
Mm-hmm.
Yeah.
I interviewed a psychiatrist in Ohio, and he says that the idea of chemical imbalance, being short of serotonin, is baloney. And his view is that everything has to do with childhood trauma before age 7, and that's foundational, not a chemistry imbalance. So in your understanding, how much of a mental illness is caused by a purely physiological imbalance, and how much has to do with trauma or whatever else that we've experienced environmentally?
So first and foremost, I think our expression today, as we sit here today, is the product of our past, right? Mm-hmm. All our past. That includes childhood, which are the formative years, and moving beyond those formative to our younger years and into our older years. So every phase of life affects us. We're more vulnerable in particular phases in life, particularly as from age 0 to 12, 14. We're the most vulnerable there. So childhood trauma definitely affects us. Trauma in relationships in early 20s and 30s, that's a different phase. That affects us if we're 50, right? Mm-hmm. If we had a divorce when we were 30, it's going to affect us. Different than someone that did not have a divorce when they were 30. The chemical expression of all those events equals what we are today. And if we're symptomatic and our serotonin is low, it has been affected by childhood trauma, by an alcoholic parent, by a messy divorce, and an abusive boyfriend. And that is the expression of the past. If we take an antidepressant that increases our serotonin, which means that means that increasing our serotonin helped us, right? That is taking the environmental considerations. There is then a subset which is predetermined by genetic predisposition that makes us vulnerable to events in our life affecting us in a much more significant way than it would affect others. A breakup in high school, we get over it in two, 3 months. There's no lasting effect. Someone with a genetic predisposition is pushed over into a lifetime of depression. Those are different because there's that stronger genetic component that has a genetic impact and predisposition.
Yeah, I've read that about half of our predisposition to be happy or not is genetic. And they've seen that with studies of identical twins separated at birth, that they have similar reactions throughout their life. I'm wondering how much, what's the chicken, what's the egg, how much of our mental health is our genetic inheritance and how much is our environment. I mean, obviously they interact, but from what you've seen, if you're going to give percentages, how much is genetic, how much is environmental? That's probably hard to do.
That's very hard to do. Yeah.
When you think about your patients who are depressed, can you always trace, oh, they're depressed because of an environmental factor, they were resented by their mother or whatever it is?
As one gains more experience just by practicing, you are identifying different things in a patient as they walk in, as pushing you to think about a particular illness and question them regarding their exposure to certain things in their lifetime. That is more experience. Our job is, a lot of it is really observational, as it is talking, but it's more observational. So we associate certain things with certain illnesses by experience.
Can you give an example of a pattern that you've seen?
I'm not going to go into details, but I think I've started recognizing the physical appearance that is associated with sexual trauma and how it can be different depending on the type of trauma. It's interesting.
That is interesting.
Yeah.
Well, is there anything that you would like to add for people to think about how to thrive during the pandemic and isolation and maybe more domestic violence issues and anxiety and OCD? I mean, anything else that you would suggest to people to how to get through this in one piece?
I think the main thing to remember is we have a lot of anxieties about the uncertainties in our lives for the next 2 months. We are going to get through it, and we are going to come out on the other side intact. Life throws curveballs at us all the time. This is one of them. I'm hoping that at least in California, we've done the right thing for the most part, and the growth of the virus is taking a different line than the rest of the country. So I'm anticipating a shorter period of time. We are going to get out of this. We're going to go back to our lives as it was. Might be a little bit different, but such are life experiences. So.
You know what I always think about is the Syrian refugees in cold, damp tents and muddy fields, struggling day to day. That makes our little struggles seem pretty insignificant.
Human struggle is never insignificant because we are in a different situation. What it does though is just put into perspective. Um, we are privileged as a society in the United States compared to the rest of the country. We should be thankful for that. And the anxiety is really about losing it.
Mm,
We're holding on with dear life, you know. We don't want to step back.
mm,
We're afraid of the past.
mm. Last question is, some psychiatrists came out and wrote a book and said Trump is a narcissistic sociopath. And other people said, well, you can't really judge someone you haven't examined, but do you want to comment on that diagnosis?
I think it's absolutely right that you cannot, it's unfair to comment on someone using medical terms if you have not examined them. I experienced the same thing during the spring uprising, and as leaders were deposed, they were called a lot of names, a lot of bad names, and you can't really use your medical knowledge to say, well, they're narcissistic, and it's somewhat unfair. That being said, there are general characteristics that jump at you that could be interpreted in medical terms, but that's where it should stop. Not a diagnosis, not a label.
But how would you define a sociopath, and what's the difference between a psychopath, sociopath?
Uh, um, in terms, they really are the same, basically. They're derogatory names more than they are anything. They're older names that we've used in the past. Modern names are antisocial behavior, antisocial personality disorders, things of that nature that indicate a pattern of lack of caring for others, lack of empathy, engagement in destructive behaviors towards animals, fire setting. These are actually indicators in history, in your history taking, that show those traits. They vary in severity as well.
Hmm. Okay.
Yeah.
Thank you, thank you, thank you.
Welcome.